Thank you, Sandra. and Good morning, everyone. Thank you for attending. I want to first cover just some objectives of what our presentation this morning will be covering. As Sandra mentioned, the primary purpose of this presentation is to discuss Down syndrome and Alzheimer's disease and the links between the two conditions. I want to illustrate the early signs and symptoms of Alzheimer's disease in people with Down syndrome, discuss what the current treatments are, what some emerging prevention strategies are, and discuss a bit about the research that we're doing here at UCI on the condition. And then you will hear a illustrative case history of Sharon's journey with her sister, Robin. I want to first point out the fact that people with Down syndrome are living much, much longer than they ever have in the past. As you'll see on this graph in the left, this is the average age, if you will, of people with Down syndrome across time. And you can see the very dramatic shift in life expectancy in people with Down syndrome that occurred in about 1970. People with Down syndrome now have life expectancy of 60 years of age. So more and more people with Down syndrome are living into middle adulthood. The graph on the right illustrates that fact quite nicely. If you look down at the lower left corner of that graph, you'll see the year 1950. And you can see the proportion of individuals with Down syndrome that were under the age of 15 was about 50% or so. And there were very few people with Down syndrome that were ages 40 and above. But if you follow the trajectory of that slope into the year 2010 or so, you'll see in the upper right portion of that graph, there are many, many individuals now living with Down syndrome into their 40s, 50s, and 60s. The primary reason for this dramatic increase in life expectancy is related to the fact that healthcare in childhood is so much better than it was in the past. So those early childhood deaths that were driving that average down are no longer occurring. People with Down syndrome are getting their cardiac abnormalities fixed in early childhood. They're not being institutionalized like they were in the past. They're going home, living in their loving family homes. Chronic lung infections that were common in children with Down syndrome are now being treated by antibiotics. So we're not seeing those early childhood deaths. So with more and more people with Down syndrome living into their 40s, 50s, and 60s, we're starting to learn a lot more about what particular health conditions people with Down syndrome experience as they age. And in general, people with Down syndrome are at risk for the same sorts of health issues as the rest of us are as they age. But I want to point out a few conditions that they're at greater risk for. So both in childhood and in adulthood, hypothyroidism is more common in people with Down syndrome. Sensory impairment, so vision impairment and hearing impairment with earlier ages of onset are much more common in people with Down syndrome as they age. Cataracts is a condition we tend to associate with advanced age, but in people with Down syndrome, we can see cataracts even in the 30s, 40s, and 50s. Hearing loss, as I mentioned, is also quite common in adults with Down syndrome. Some mental health disorders are a bit more common: obsessive compulsive disorders, anxiety, depression. A condition known as obstructive sleep apnea is also much more common in people with Down syndrome. They're at risk for this condition, which is basically an obstruction of the airway during sleep. The primary reasons they're at risk for this condition relate to the ligament laxity, the structural differences in their face and their neck. So when they lie down to sleep at rest, their airway can get blocked primarily by their tongue sliding back and blocking the airway. Obstructive sleep apnea is a condition that all children and adults with Down syndrome should be screened for. Osteoporosis that can result in brittle bones and fracture risk is more common with people with Down syndrome as they age. Osteoarthritis is as well. So arthritic changes in the joints and spine do occur more frequently in middle adulthood. Obesity is more common in people with Down syndrome, and as a result, type 2 diabetes as well. A condition known as celiac disease, which is an immune condition where the lining of the gut is sensitive to gluten. I think we've all heard gluten-free diets nowadays. It's much more easy to find a gluten-free diet in the supermarket and at restaurants to try to treat this condition where there's a sensitivity of the gut lining to gluten, which is a protein that's found in grains such as wheat, barley, and rye. Atlantoaxial subluxation is a term that's probably not unfamiliar to most of you. The atlantoaxial joint is the joint at the upper part of the neck that connects the skull. The ligament laxity can present an issue in Down syndrome where there's too much movement in the vertebrae there. And that excessive movement can result in impingement of the spinal cord and can lead to neurological complications. And then, of course, early onset Alzheimer's disease is another condition more common. So I want to just start by giving a definition of what dementia is. The word dementia is an umbrella term that describes a set of symptoms that may include memory loss, difficulties with thinking and problem solving, language impairments, and it often includes changes in mood and behavior. The term dementia, as I said, was an umbrella term, and there are many things that fall under that umbrella. Some of them are irreversible dementia, such as Alzheimer's, vascular dementia, Lewy body dementia. You can see some of those terms under the umbrella here. Alzheimer's disease is the leading cause of dementia, followed probably by vascular dementia. But there are some dementias that are reversible. So dehydration can have an individual present with a dementia. Vitamin B12 deficiency, adverse effects of some drugs can do that. Hypothyroidism can also do that if it's untreated. And it's important to note that dementia is not part of normal aging. So again, Alzheimer's disease is one form of dementia. So in Alzheimer's disease, the brain cells are surrounded by an abnormal proteins called amyloid and tau. We're going to discuss those a bit more later, but these abnormal proteins damage the internal structure of our brain cells, and over time it interrupts the chemical connections between brain cells as well, and it actually results in death of brain cells. And it's the destruction of these brain cells that causes the memory failure, the personality changes, the problems carrying out activities of daily living, and the other symptoms of Alzheimer's disease that we're also going to cover in more detail in a bit. And it's important to recognize that Alzheimer's disease is a progressive brain disorder, meaning that symptoms will get worse over time. And as I said, Alzheimer's disease is the most common form of dementia in people with Down syndrome. So in people with Down syndrome, all individuals are known to develop the neuropathological hallmarks of Alzheimer's disease by age 40 years. And these hallmarks are the amyloid plaques and the tau tangles, those two proteins that I mentioned that build up in the brains of people who develop Alzheimer's. But even though they develop the pathology, dementia at age 40 is quite rare. But starting at age 40, that's the time period where we want to be suspicious of potentially a dementia-related change. And that age where we want to start to monitor for dementia-related change. And as I said, with life expectancy being 60 now, many people with Down syndrome live into their risk years. But it's important to recognize that even though the dementia associated with those brain changes is very common, we don't see dementia in everyone with Down syndrome. So the best figures we have to date in estimating the incidence of Alzheimer's disease or Alzheimer's dementia in people with Down syndrome are illustrated here, where we think about 20% of people with Down syndrome over age 40 will have symptoms of dementia. About half of the individuals over age 55 and about 3/4 of the individuals over age 60. The average age of onset of dementia in people with Down syndrome has been shown in multiple studies to be right around age 52, 53 years of age. When we see Alzheimer's disease in people with Down syndrome, it tends to be a more rapidly accelerating course. So the progression typically lasts around 5.5 to 6 years from early stage dementia to end stage. But the range is quite broad, most typically between 2 and 9 years. So why do people with Down syndrome have this high risk of developing Alzheimer's disease? And as you might imagine, it relates to chromosome 21, the chromosome that's triplicated in people with Down syndrome. You've all undoubtedly seen a karyotype of an individual with Down syndrome, where instead of having 2 copies of all the cells or all the chromosomes in our cells, individuals with Down syndrome have an extra copy or a third copy of chromosome 21. And we know since chromosome 21 has been decoded, we know a lot about the genes that are present on chromosome 21 and how they're related to the phenotype or the condition of Down syndrome. One of those genes is called APP, or the amyloid precursor protein. And this gene codes for amyloid. And as I mentioned, amyloid is one of the proteins that builds up in the brains of people with Down syndrome, people who develop ALZ, and people who develop Alzheimer's. So this amyloid precursor protein is located on chromosome 21. So instead of having 2 copies of that gene, people with Down syndrome have 3 copies of that gene. And 3 copies of that gene leads to an overproduction of amyloid throughout the lifespan. So it is believed it's this 3rd copy of that APP gene that puts people with Down syndrome at risk for the pathology of Alzheimer's disease. And the leading hypothesis to the development of the pathology of Alzheimer's and the associated dementia is a hypothesis called the amyloid cascade hypothesis. And this is a hypothesis that posits amyloid is deposited in the brain initially, and that leads to the formation of these amyloid plaques. Sometime after that, in the timeline of the development of Alzheimer's disease, this other protein named tau is deposited in the brain. And then that leads to the neuronal dysfunction that I discussed and the associated dementia. The illustrations I have here the dark brown blobs are just an illustration of amyloid in the brain. And these little bluish colored sort of teardrop shaped things are what tau looks like. So these are images taken at the end of an individual's life with a microscope and specific stains that allow us to visualize these. And here's just an illustration of how they look associated with age. And you can see between a 31-year-old, a 40-year-old, and a 54-year-old, the aggregates of amyloid increase as an individual ages. And here's a diagram I want to spend a little bit of time on, because this is our current state of knowledge about the progression of this pathology in people with Down syndrome. So if you look at this graph, this sort of red area off to the right, where it says the onset of clinical symptoms, that is the dementia that we've been talking about. So you can see with age, starting at about age 40 or so, we see some individuals become affected. As they continue to age, the risk of becoming affected with dementia increases. It never quite reaches 100%, but it does get close. But if you look to the left of this, we have learned through research that we're doing and others around the country and around the world that the pathology of Alzheimer's disease develops very early in people with Down syndrome, much earlier than a dementia is recognized. So you'll see this A beta, that refers to amyloid beta. That's the type of amyloid that's deposited in the brain. We start to see amyloid in the brain in very early life, and it accumulates even in the 20s with the NFT, or neurofibrillary tangles, or tau, another word for that, tau, starting even in the late 20s. So the field of Alzheimer's disease research has shifted sort of to this area. How do we identify people with Down syndrome who are already showing Alzheimer's related changes in their brain years before an expected dementia related change? So we're hoping one day through our research that we're going to be able to identify Alzheimer's disease many years prior to an expected dementia, and then offer preventive drug treatments. And we'll come back to this a little bit later when I talk a bit more about the research that we're doing here. So what are the symptoms of Alzheimer's dementia in people with Down syndrome? So I'll review those briefly here. Quite commonly, families will describe that they require more prompts to carry out their activities of daily living. So skills that they'd once mastered, the independent skills, say, of bathing and showering, all of a sudden they're forgetting certain steps, where they may forget to rinse the shampoo out of their hair, for example. So they get out of the shower and dry off, but then you realize, they missed that step. So they might need verbal prompts or reminders in the early stages of dementia. Of course, when we think of Alzheimer's dementia, we often think of memory impairments, where we forget things. Most typically short-term memory, so things we recently tried to commit to our memory are lost. So what we did that day, or what we did last week when we were on vacation, we forget little pieces of the activities. So our memories aren't as sharp as they once were. Things like what we had for breakfast, say. We also see changes in speech patterns or clarity of speech. So we see individuals where their speech sounds kind of slurred. It can become more difficult to understand what words they're trying to say. We can see changes in the complexity of speech. So people that spoke with full sentence speech, or phrases, 3 and 4 word phrases, you'll see that minimized a bit. You'll see changes in their orientation. So they won't be as oriented to place. They might now all of a sudden get lost in familiar surroundings, maybe turn the wrong way as they try to navigate an area that they once were familiar with. You'll see changes in their ability to remember, calendar dates, birth dates that are coming up. It's often important for them to remember family members and friends' birth dates, and you might see those sorts of memories start to slip, or what day of the week it is. And in people with Down syndrome who develop Alzheimer's, dementia, you can see new onset seizures as well. So someone that didn't have a seizure disorder in adulthood will now develop seizures. And these seizures are the type we used to call a grand mal type seizure that's now referred to a generalized tonic-clonic seizure, where there's a loss of consciousness and shaking and things like that. We also see changes in gait or walking. So they can present with difficulty in walking and difficulty with their balance. There can be just a general slowing down of walking, but quite typically, there's a gait ataxia that is often demonstrated when they're approaching an obstacle or a curb or a stair. Well, you'll see a hesitancy and almost an uncertainty with what they're supposed to do with their feet in space. So you'll see them walk very slowly, maybe want to grab onto somebody's arm, or if they didn't used to use the handrail when they went up and down stairs, they now will. Quite typically, you'll see it at a door threshold where there's just a change in the pattern of the floor. So say someone's walking from a white tile to a black carpet. When they get to that transition, they'll stop, hesitate, wonder what they're supposed to do, and then maybe take an exaggerated step over that transition before continuing on. You can also see new onset urinary and bowel incontinence. And quite important is to recognize that emotional changes are very common as an early symptom of Alzheimer's disease. As I mentioned, we all tend to think of dementia as something that affects our memory first. But quite often in people with Down syndrome, the early signs that families report and that they notice aren't related to memory, but rather behavioral changes. So you can see an individual exhibit signs of depression, social withdrawal, loss of motivation. So they tend to isolate more, say in their own rooms, not want to come out and socialize with family and friends like they once did. You can see them withdraw from hobbies and pastimes that they once enjoyed, and they can not engage in those activities with the pleasure that they once had. Changes in sleep pattern are often common as well. Waking up too early in the morning is quite common. You can see alterations in their eating habits where typically they're eating less. So weight loss is also reported in the very early stages of Alzheimer's disease. You can see increased agitation as well. You can see signs of anxiety where they weren't there before. Some of the agitation is probably related to the fact that they're recognizing that they're facing new challenges as they try to complete tasks that they'd once mastered. You can see an escalation in the frequency and intensity of long-standing behaviors as well. So obsessive compulsive traits are common in people with Down syndrome, and often those intensify as an individual transitions into the early stages of Alzheimer's. I just wanted to show an illustration here of some colorings that one of our past patients and research participants shared with us. And There's a 6-month example between these colorings, with the first being this caterpillar here. And you can see how neat and nicely that caterpillar was colored. I want to point out that she was already in the early stages of dementia when she drew that caterpillar, but you can see 6 months later with the character here in the snow scene and whatever this sort of, I guess it's a sloth over here in the lower left. But you can see with each 6-month interval, there's a pretty dramatic loss. So when I said earlier that when we see Alzheimer's disease in people with Down syndrome, it tends to be a more rapidly progressive course. This is an example of how rapidly things can be changing. And as we mentioned earlier, you're going to hear quite a bit more from Sharon later when she discusses how her sister Robin presented and progressed through her journey with Alzheimer's. So how do we assess Alzheimer's disease in people with Down syndrome? There is no formal diagnostic test or criteria that's currently available. There's no blood test, there's no brain scan that would really definitively diagnose Alzheimer's disease. The field is moving towards the day where we might have such a test, but we're not there yet. The assessment for dementia in somebody with Down syndrome is complex because the lifelong intellectual disability of people with Down syndrome can vary widely. So you have some people with Down syndrome that are lower functioning and others that are higher. So an individual with Down syndrome who was lower functioning, maybe nonverbal, may have never been oriented to day of the week, month, or year. So when you ask them those memory challenges, what day of the week is it? They may not know because they never knew. Or an individual with Down syndrome who was higher functioning, you ask them what day of the week it is, they may not know because they're forgetting now, because they once knew, but Alzheimer's disease has caused them to forget. So when we assess for Alzheimer's disease in people with Down syndrome, we really have to have a good understanding of what that individual's baseline abilities were. So developing a good profile of that individual is imperative. And as I'll describe in just a moment, there's a new tool that we all have available to us that allows us to characterize a lot of those baseline skills in our loved ones with Down syndrome. So we can document that baseline now with a tool that I'll describe. And it's important to recognize that assessment for dementia in people with Down syndrome relies very heavily on a knowledgeable and reliable informant, and that tends to be family members, caregivers from group homes, even staff in their workshop or their workplace or their day programs can provide critical information to a clinical team that's assessing for Alzheimer's disease. It's also important that we conduct a differential diagnosis, because many of those medical conditions that I mentioned that are more common in people with Down syndrome, the vision impairment, the hearing impairment, hypothyroidism, depression, changes in disruption in our sleep, those are conditions that commonly mimic dementia in somebody with Down syndrome. So we sometimes see an overdiagnosis of Alzheimer's dementia, where it's an individual with Down syndrome that has a sudden onset hearing loss, and now is unable to hear, unable to follow instructions, appears confused, and is all too often labeled as demented. But that individual who might just need an ear cleaning and a hearing aid. They can return right back to their baseline level. So this differential that we have to assess is actually quite broad. And it's important to reassess the individual at established intervals to try to assess change. We have some diagnostic tools that we use. Of course, a good medical history and a review of past medical charts can be helpful. Physical as well as neurological exams are often helpful. There are some assessments we use primarily on the research side, the Down Syndrome Mental Status Exam, Severe Impairment Battery, Rapid Assessment for Developmental Disabilities that allow us to characterize areas of cognition and function and behavior that might be related to dementia-related change. But this one tool under the dementia scale assessment heading called the NTG EDSD was developed by the National Task Group for Intellectual Disabilities and Dementia Practices. The EDSD is the early detection screen for dementia. And that's a tool that we all have available to us. We can certainly make a copy available to you as well, so you can have it as a tool to complete that will allow you to characterize baseline abilities. And the current healthcare guidelines recommend that to be completed for every adult with Down syndrome starting at age 40 and annually thereafter. There's some neuropsychological assessments that can be used as well. As I said, the differential diagnosis of depression, say, can mimic dementia. So there's some indexes that we use there, measures of adaptive behavior as well. So there's self-help skills. We have measures as well. Brain imaging I have on this slide because brain imaging can not necessarily diagnose Alzheimer's disease, but it can rule out some other brain conditions that might mimic dementia. So things like MRI scans can often be done to make sure it's not something else besides Alzheimer's that's affecting brain health. So what sort of treatments are available for Alzheimer's disease? And the same treatments that are FDA approved to treat Alzheimer's in people without Down syndrome are used in people with Down syndrome. The studies that have examined how effective they are in people with Down syndrome are quite mixed. Some studies suggest they're not effective at all in people with Down syndrome, and other studies suggest they're as effective in people with Down syndrome as they are in people without. But that said, it's important to recognize that these treatments are minimally effective at best, and they really don't do too much to change the progression of the disease. But currently, they're really all that we have. But as research is progressing, there are a lot of potential treatments that are in the pipeline that might be doing something to shift the needle a bit and maybe even potentially get us to the point where we're able to prevent Alzheimer's disease in people with Down syndrome. And some of these drug therapies target the deposition of amyloid and actually are able to remove amyloid from living brain. And these drug studies are just now being undertaken in people who are at risk to develop Alzheimer's. And hopefully in the next few years, we'll get some treatment trials in people with Down syndrome. So there are some risk reducing strategies that some of us might want to consider. These studies have been done in people without Down syndrome primarily, but a few studies, even by members of our group, have been done in people with Down syndrome. And there are some risk reducing strategies that look promising. So of course we want to manage medical conditions that may increase risk. So obstructive sleep apnea, say, or hypothyroidism, or these hearing and vision loss issues. Eating a healthy diet, it's primarily thought of as a heart healthy diet. It's probably a brain healthy diet as well. Getting regular exercise may give us some protection as well. Staying socially engaged and active, keeping our brain active and stimulated with intellectual activities, and getting adequate sleep. And it's thought that 7 to 8 hours of sleep each night is adequate, and might be doing something to preserve brain health. So I want to talk just a bit about our research program here at UCI. We have a clinic as well where we assess and treat people with Down syndrome who may be experiencing signs of dementia. Our research program is primarily looking at what we call biomarkers of Alzheimer's disease. And these are analytes that we can analyze in blood samples and spinal fluid samples, through some of our brain imaging scans. We use PET scans now that can actually quantify how much amyloid and tau is in living brain. And even 5 years ago, these sorts of things were not possible on the research side. We have a brain donation and brain autopsy protocol here at UCI as well. We have a psychoeducational support group that's a collaboration with Alzheimer's Orange County, the Regional Center Orange County, and the Down Syndrome Association of Orange County. But as I was trying to describe earlier, the whole field of Alzheimer's research has really shifted to this area where these blue and green patterns are on this curve, where we're trying to identify people that essentially have Alzheimer's disease in the decades before an anticipated dementia-related change, and then work with scientists who are developing drugs to treat some of those brain changes, such as the removal of amyloid, to shift this needle and maybe even prevent Alzheimer's in people with Down syndrome. Oh, excuse me. I have 2 research flyers here that are ongoing studies here at UCI. One is open to people with Down syndrome age 18 and above, and the other is a multi-center study that's open with people with Down syndrome age 25 and above. And if anybody would like to hear more about these studies, please reach out to me, and Sharon and I are going to share our contact information at the end of the presentation. So in summary, the association of Alzheimer's disease in people with Down syndrome is well established. It primarily relates to this triplication of that APP gene that leads to the overproduction of amyloid, that leads to the cascade that I described, that most typically results in a dementia-related condition. But it's important to recognize that even though all persons with Down syndrome develop the pathology of Alzheimer's, not all individuals develop the dementia. And there's something to be learned there. You know, I've described a lot about what puts people with Down syndrome at risk, but why some individuals with Down syndrome escape dementia is also a primary focus of our research here. There's something that needs to be learned about those individuals that live into their 60s and beyond that don't develop the dementia, despite the fact we know they have the pathology. So if we could learn why those individuals aren't transitioning, there should be some clues there that will lead to potential treatments for all of us, not just people with Down syndrome, but probably for the general population as well. And with that, we'll transition to Sharon's part of the talk.
Thank you so much, Eric. And at this point, I anybody has questions, you can unmute yourselves. And there's a question in the chat. Let me see.
I'll have a look.
It says, does the development of central sleep apnea correlate with dementia in adulthood?
You know, so that I don't see the question, but that you're asking, does the question, does sleep apnea correlate with the development of dementia in people with Down syndrome? Did I hear you right?
I think that's what they're asking.
Yeah, I don't think we have good data yet to definitively say that, but more and more data is coming from both people with Down syndrome and people without, that disruptions in sleep of any type, and sleep apnea being a primary driver of sleep disruption in people with Down syndrome, do in fact increase the risk for Alzheimer's dementia. But these are only recent studies, and we can't say with certainty that there's a direct link, but it's looking more and more like that changes in sleep, disruptions in sleep do increase risks. So that has been a primary focus of our recent research as well.
There are a couple of questions in the chat. Let me go over here. If you want to ask your question, maybe it's best if you raise your hand and ask your question. That way we can kind of record it a little bit.
We are using AI algorithms in our brain imaging research. We have some very talented scientists that are actually just starting to do that sort of work now, because we're finally to a point in this multi-center study that we have that's funded by the National Institutes of Health called ABCDS, Alzheimer's Biomarker Consortium for Down syndrome. We're acquiring a large number of MRI scans, of PET scans that allow us to quantify amyloid, PET scans that allow us to quantify tau. And our talented scientists are now just beginning to use AI to try to analyze these brain scans. So that's the answer to that question. Cutting edge stuff there. I'm not seeing any other questions there, but
iPhone has a
sure.
Hand up. You can, let's see, you can ask your question. I don't know the name, but it just says iPhone on it. So
someone can unmute the iPhone.
Yeah. Okay.
Maybe we'll allow Sharon to give her portion of the talk, and then we'll stay on for questions too.
All right, yeah, I don't know what happened. So we lost that person.
Yeah, I'm not hearing anyone.
Can I ask a quick question?
Sure.
My son, and I'm sorry, I want to make it personal. My son, he was, of course, born with Down syndrome, and he was also diagnosed with autism. And you were talking about behaviors that intensify, and I know he's only 23 years old, and I don't know if it's all related to COVID, but some of his behaviors have intensified, and it could be COVID related, like, you know, using a lot of hand sanitizer, wiping everything in the house. Just different behaviors. He doesn't want to touch people anymore because, you know, I don't know if it's related to COVID. And how do you know what?
Yeah, that's a good question.
Like
so
how do you know?
The sorts of behavior changes that I'm referring to that intensify in the early stages of an Alzheimer's dementia aren't the sorts of things we would see in somebody in their 20s and 30s. And they tend to be, say within the first year of us recognizing that there is a dementia in the individual. So oftentimes it's when we look back at what the earliest signs were, we point to those behavior changes, but we only have to go back, say, a year or so. And then the individual will present clinically with other changes. So then you'll start to see the memory changes, the confusion with carrying out activities of daily living, say. So when families tell us what they believe was the earliest signs, they'll often point to behavior changes, but they tend to be, say, 1 and 2 years before there's a diagnosis of a dementia, not decades before. So I wouldn't be too suspicious of behavior changes in the 20s and 30s. Hope that answered your question.
Thank you so much. And we'll answer more questions after Sharon's presentation. Thank you so much, Sharon. Is she around? Let me see.
I'm here.
Oh, there she is.
Should I go ahead and start now?
Yes, please. Thank you so much.
Well, thank you very much for having us here. And I want to, the best resource I had during Robin's journey was UC Irvine. The clinic there was so helpful. And Eric and Dr. Tournay, who is since retired, were so helpful. So I honestly don't know what I would have done. So if you can get connected with them, it's really wonderful. The pictures that are up are of my sister Robin, and some of you knew Robin. Robin had a twin brother. His name was Tony. When Robin was brought back from the hospital with Tony, we were told to treat them exactly the same. So if Tony was learning to walk, Robin was learning to walk. If Tony was learning to read, Robin was learning to read. If Tony was riding a two-wheel bicycle, Robin was riding a two-wheel bicycle. And the family worked at that. The family put the time in so that Robin could be part of life with Tony. Robin loved being out. She loved field trips. She loved costumes. She loved the marathon. She loved performing. She played Sue Sylvester's sister in Glee. She loved music. She could pick out songs on the piano. She played Greensleeves at my wedding. She loved costumes. So Robin was very active, filled with life, and loved to have fun. And, you know, this to me was great because she moved out here to be with me after the death of both of our parents, the death of her twin brother. So she had a lot of grief in her life. She moved out here and had to leave all her friends, all her life as she knew it. But she was able to put together a really nice life out in California. Eric, could you forward, please? I have this book here. Robin was part of a program called LA Goal, GOAL, in Culver City. She was one of their resident artists. And could you forward again, Eric? And this was her artwork that she did for this fable. That was a project that they had there that they turned to a book. Part of what they did was they had to write their stories. And this is Robin's story. My name is Robin Trocki and I have Down syndrome. I'm not really happy about that, but I don't let it get in my way. I'm not different from anyone else once you get to know me. I live in my own apartment with a roommate. I work in the bakery department of a supermarket. I'm an athlete, an artist, a musician, a student, a good friend, and a happy person. I always try to be helpful. I have a good life and I'm very honored to be in this book. We were at LA Goal one day. I was at a volunteer meeting and Robin was reading the book while I was there. And when I came out, she said to me, "Have I changed?" And I asked her, "Do you think you've changed?" And she said, "Yes, this isn't my story anymore." And Robin was very aware of what was happening to her and very very verbal about it. So she said, I need a new story. And this is Robin's new story. My name is Robin Trocki and I have Alzheimer's. I'm not very happy about that at all. Everything I worked so hard to learn is being taken away from me. I can't dial the phone or tie my shoes. I can't remember how to dress myself or write my name. I can't get on an escalator or step down a curb. I'm afraid to walk because I fall a lot. This is embarrassing and scary for me. I get confused, which I hate. And I love this because being confused confuses me. I agree with her. My friends get mad at me when I say the same things over and over again or call them by the wrong name, which I do all the time. It makes me feel like they don't like me anymore. My days are hard for me, but my nights are really bad. I get very scared. I don't like the dark because I see things that I'm afraid will get me. I'm lost. I am trying very hard to find my way, but it's too hard. I need hugs. I need to know that someone is there for me because I don't want to be in this scary place alone. Now, Robin is talking about, she's further along when she writes this story. I want to go to what the early signs that we saw. Eric, could we go to the next? Thank you. The first things that started happening, Robin began falling. We had no idea why she was falling. She would just fall. And the staff, her staff at the time said, she's just trying to get attention. She's doing it to get attention. She started having emotional outbursts, little bits of depression or sadness or anger. And at the time we said, oh, menopause, it's menopause. She began having difficulty at work. She'd come home. She'd been working at Ralph's for 17 years and had never really had problems there. And she came home complaining all the time now. And all of these things got put back on her. Robin, you need to pay more attention at work. You need to be more careful. You need to, she also, I didn't notice this at first, but her speech did begin to change. And we were having lunch one day with someone and they said, Robin went to use the restroom and he said, what's up with Robin? I used to be able to understand everything she said. Now I'm having a hard time. So again, this became Robin's problem. You need to speak clearly. You need to slow down. You need to pay attention. And she couldn't. She couldn't. These were the early signs. This was about when Robin was 50, 49 or 50. These changes started to happen. This was maybe 16 years ago. I knew nothing about Alzheimer's. I knew nothing about the connection between Down syndrome and Alzheimer's. And so these became Robin's problems. She wasn't performing up to par. She needed to do better. And that's so unfair. You know, looking back, it's so unfair. So we can see here, she was having changes in her behavior. There were changes in her speech. She was having difficulty. She was starting to pull away a little bit, but I didn't even really notice that. The problems at work were a decline in her ability to pay attention. And she did start staying up at night. And that became a problem again with the staff. The irritability or any aggression got attributed to menopause. The increased excitability got attributed to menopause. And the changes in coordination were her seeking attention. So we just didn't know what was happening at the time. And I can only see all of this so clearly by looking in the rearview mirror. And I think it's important to have this information out there so they're not being held accountable for brain changes that they can't do anything about. Eric, would you go on to the next? So eventually the things that Robin, we began to see in her, and it's a progression, and you can really see the progression. At first, Robin was fine with just a few little things happening that we had no idea why they were happening. As it progressed and the pacing started, the repetitive questions, rummaging, she would be up at night moving things around. One day she took all the food out of her freezer and put it in her sock drawer, which the staff was not happy about the next day. So there were verbal outbursts, agitation. She did eventually start to experience paranoia and hallucinations. And those ended up being very severe. The paranoia and anxiety, she wouldn't even come out of her room. She got so upset and so locked in. And we put her on her primary care physician prescribed Ativan. And fortunately, because I was working with Eric and Dr. Tournay, I was advised to ask for the smallest possible dose. Our people with Down syndrome have different reactions often to medications and can be over-medicated quite easily. So any medications, Robin was eventually put on Seroquel for her paranoia and hallucinations. I would ask for the smallest possible dose and titrate up very slowly. Would be start low and go slow. And the doses that she ended up on were very, very small. In fact, one time I took her to a doctor and he said, go home and double those doses. No, I was not going to do that. The doses she was on were what were working for her. And as the caregivers, we have to be advocates on every level with doctors, with caregivers. Eventually, Robin's behaviors were very connected to her dementia. And it's important to have caregivers who understand what's going on and know what they're doing. And it's important to make sure that staff at programs are trained to understand this and to work with this. Robin did experience sundowning, which when it started to get dark, she'd get more agitated. Eventually, she wasn't so much resistant initially to personal care. She just was not remembering about it. If you said, go brush your teeth, she'd do it. Eventually, she had difficulty brushing her teeth. And there were changes in personality with her. But so much of it, again, got put on her, and she's doing this on purpose, which at the time we didn't know, we didn't understand about Alzheimer's, but the fact is she was not doing any of it on purpose. These were signs of changes in her brain. Eric, could you move to the next one, please? As caregivers, I found that as Robin moved through her Alzheimer's, I was blindsided again and again and again. I was put in positions of, this is what's happening with Robin, what are you going to do about it? And I had to utilize resources. I had to figure out what was going on to the best of my ability. And it put me in a position that, well, Robin is being confused, I'm confused too. I'm afraid, I don't know what's happening. And that's significant for me as a caregiver, because I didn't know way back then what resources to look for. I didn't know what to do. Today, I would recommend calling Eric. As soon as this is over, call Eric. And so what we need to understand, Robin no longer saw the world the way I did. You know, we were walking through the mall one day, and we'd done this hundreds of times. I'm right next to her, I get on the escalator, she freezes. I'm like, Robin, get on the escalator. And she's there yelling, I'm afraid, I'm afraid, I'm afraid. And that was new behavior because Robin didn't see the escalator the same way I saw it. She didn't see it the way she used to see it. It became very frightening to her. So what I was seeing as normal, she was seeing as very confusing and threatening. And I needed to understand that. I needed to understand that she was lost. And I had to provide her with, I had to be the North Star that she could follow as her caregiver. Her staff had to give her prompts and be the people that she could follow. So we really had to enter her reality because she couldn't conform to our reality. We had to be patient, supportive, and understanding. And it's easier to be patient, supportive, and understanding once you know what's happening. But when these things first start, they don't seem like Alzheimer's. It just seems like someone's being uncooperative. It seems like someone's seeking attention. So it really is important to be, for me to be educated about this. And I had to change because she couldn't. I had to find ways of being there for her. And I have to say, we had the ideal situation. Could we have the next slide, please, Eric? Robin, when she stopped walking, moved into my home, and I was committed to keeping Robin's life as normal as she liked it. She liked to be busy. She liked to be doing things. And it breaks my heart when I see people left sitting doing nothing. So the first picture of Robin with her pink cat, she's having a shake. We really did a lot with her nutrition, and we had to follow, first she could eat, then she needed to have food cut, then she needed mechanical chop, then she needed puree. We kept everything balanced. We had vegetables, fruits, fish, and chicken, and really had to keep conscious of things like constipation, like vitamin deficiency. We stayed on top of that. When Robin was in the wheelchair, she couldn't get up and move around anymore. So I found this little exercycle that plugs in, and we would tie her feet to it, and she could sit and pedal, which was exercising and getting her blood flowing and keeping her moving. Robin was very affectionate. She loved hugs. She loved having her hand held. So instead of leaving her in the wheelchair or in the hospital bed, which I moved into my living room, we would do couch time. Me or the caregivers would sit on the couch with her and hold her to keep that contact, to keep that the touch, the sense of safety and care. We would get her to as many outings as possible. If something was going on at ARC where she had her day program, we'd get her to that so she could visit with her friends. We'd take her out on trips. This is her on a beach wheelchair, and you can get these beach wheelchairs, and we had to tie her in because she couldn't sit up anymore. And here we are at the Equestrian Center. We took her to the World Special Olympics when they were here. We took her down on the subway. She loved being out, and we kept her out. I was able to get fantastic caregivers who were there for her and didn't just sit on the couch playing on their cell phones, didn't just talk on their phone. They were there for Robin. They read to her. They held her hand. They took her out for walks. Robin was dressed and out in her wheelchair every day, except 4 days before she died. She was out every day, being in the community, being active. And that was very important, not only to her, but to me. And I know when people end up being in a group home or a skilled nursing facility, I was with Robin every day. if you're not with them every day, you can check in on things and suggest what can happen, and hopefully maybe get some one-on-one care, because as advocates, we have to work with the regional centers, we have to work with the doctors, we have to work with the nurses. We had nurses and doctors coming to the house, and they really wanted to keep giving Robin medication, more and more medication. And when she didn't need it, I wouldn't let it happen. And that became important as well. So I'm a little bit over here. Eric, could we have the next slide? The other thing that was extremely important to me was being in a support group. I started running a support group with the Alzheimer's Association of Los Angeles. And our first night, 7 people showed up. The group was an hour and a half, and we were out in the parking lot probably for another hour, hour and a half, because people just needed to talk. They needed to tell their story. They needed to hear what other people were going through. They needed to share resources. We have a support group today through Alzheimer's Los Angeles. That's a Zoom group that meets the first and third Wednesday of the month on Zoom. Alzheimer's Orange County has a group that meets in person. They meet the second Friday of every month from 1 to 2:30 if you're in that area. And there's also a national support group that meets the first Thursday of every month. And they have speakers in, they share a lot of information. And these support groups were so helpful and so valuable to me, because I needed a roadmap so I could guide Robin on her journey. And left to my own devices, I had no idea, but with other people, it helped. So here's the contact information. If you'd like to contact Eric for testing or information or finding out about the research projects, his phone number is there, his email is there. And I have to tell you, he's amazing. What they do there is wonderful. And my information is there, my phone number, my email with the Alzheimer's Association Los Angeles. And I would love to talk about, both Eric and I will answer any questions, or if you call, try to be helpful in any way that we can. Is that our last slide, Eric?
Mm-hmm.
Okay, so if we still have, I know we've gone over already, but if there are questions still remaining, Sandra, if it's okay to stay on and answer them, I think both Eric and I would like to do that.
Yeah, sure. If anybody has questions, please, you can raise your hand or unmute yourself.
Sharon, I see one in the chat where someone was curious, what age did Robin start to show her early signs?
Around 49 or 50 was when, and I think it was happening before then, particularly with just emotional changes. But again, because we were saying, oh, it's menopause, I wasn't paying attention to them. And each thing came up individually. It wasn't until the whole picture came together. And I went to a workshop about Alzheimer's and Down syndrome put on by the regional center way back when. And then all the pieces came together for me, and I saw what was happening.
Hi, this question is for Eric.
Yes.
So you mentioned that some people with Down syndrome, they will progress with Alzheimer's, but not necessarily have dementia symptoms. Can you further explain that? Because I'm always confused between Alzheimer's and dementia. I know that you said dementia is an umbrella and Alzheimer's is the cause, but then how do they have Alzheimer's symptoms, not dementia?
Yeah, that really is the leading scientific question, right? That's the confusing piece here. It used to be thought that there was a one-to-one relationship between the brain changes of Alzheimer's that I described and the dementia. And that's primarily because research scientists were looking at the brains of people with Down syndrome, I mean, of people, well, both people with Down syndrome and people without, who died after experiencing a dementia. And they would see these amyloid plaques and tau tangles. But then, of course, we've learned more and more, both in people without Down syndrome and people with Down syndrome, you can see significant levels of amyloid plaques and tau tangles in brains of individuals who do not show symptoms of dementia. And that's the part of our science that we're trying to understand more fully. And it's probably, so I went back to this graph here that shows, the red was the demented area, and then the blue and the green being the amyloid and tau accumulation. The field of Alzheimer's disease is trying to define the clinical entity of Alzheimer's disease as a measure of these sorts of changes that we are seeing on the research side of things. So amyloid and tau levels in blood, in spinal fluid, and in brain, and other analytes that may be indicative of Alzheimer's disease, and then develop ways to intervene and treat much earlier in what is presumed to be a course that will eventually lead to dementia-related change. So this is a primary area of research, not only in people with Down syndrome, but in people without. And the sorts of work we're doing here, funded by the National Institutes of Health on this Alzheimer's biomarker consortium, is happening actually in unison across other research collaboratives and consortiums around the country and around the world in people without Down syndrome. So people at risk for early onset Alzheimer's, which are rare, but there are a number of other genetic conditions, not just Down syndrome, that might put people at increased risk for early onset Alzheimer's, but also in people at risk for just what we typically think of as Alzheimer's, the late onset Alzheimer's that we're all at risk for when we enter into our 70s and 80s. So the sorts of research that we're doing is the same as what those other research groups are doing. And they're too targeting this sort of Alzheimer's disease in the years before there's an anticipated dementia-related change. So I hope that helps.
Eric, I just want to go over to Sandra now. I'm going to talk about Robin's experience, and then I'm going to put the question over to you. She says, my son talks about shadows touching him, and he has both visual and auditory hallucinations, as well as delusions and paranoia. He's only 39, but he isn't the person he used to be. Anger, isolation, and crying. When Robin became very afraid of the dark because she was seeing things in shadows, and I had to leave lights on all the time. She couldn't be in the dark. And eventually what we ended up doing was giving her Seroquel that helped with that. Now, we know that was definitely related to her Alzheimer's. Because your son is 39, I'm going to put the question over to Eric, whether is there a differentiation between Alzheimer's disease and psychosis, or could this be part of, is 39 too young, or is that possible?
If I could just add that he's on Seroquel now. We had to up it. He's on 300 a day now, and it still isn't helping a whole lot. He also will not. He has to sleep in my bedroom. He won't sleep in a room by himself anymore.
So Eric, what's your experience?
Yeah, it is a difficult question. Most typically when we see the emergence of behaviors like this, in an individual who did not have them as part of adulthood. They tend to be more associated with recognized dementia, symptoms that don't necessarily present in the very early stages of that dementia, but maybe more towards middle stage would be most common. But you bring up a very good question here, and one that we would like to understand ourselves. As we describe the pathology of Alzheimer's is present in the brains of all people with Down syndrome, even at this age of 39. And we don't necessarily know if it's totally benign, in the absence of leading to dementia-related change. So it's possible that some of the behavior changes we're seeing in individuals in their 30s might be related to the pathology, but we just don't recognize it yet. How long has your son had issues with hallucinations and delusions? Is it something that's been part of his normal adult life, and
No.
it's just intensifying now?
No, he wasn't like that before. It's probably been about a year now, but I've been seeing some cognitive and even physical ability changes for about 3 years.
Yeah, it would certainly warrant an assessment for dementia. I don't know if that's been suggested already.
Yeah, he's done a baseline with a neuropsych.
Good.
He's had most everything checked.
Yeah, it would be unusual to see dementia prior to age 40. Extremely rare, but it has been reported in some individuals as young as the late 30s.
Thank you.
I wanted to add that Dr. Santoro is also doing more research, or I guess he already published a paper on regression in Down syndrome. And a lot of times those regressions are related to something somewhat different. So he's going to be presented in September regarding something else, but you can also ask and see if you can have a consultation with him. He sees adults, even though he's at Children's Hospital, UCLA also, I believe. But he also sees adults. So that's something that you could try to get an assessment.
Can you put the name in the chat for this doctor?
Yes. And I also have a question for for Eric. The research that you have right now, are you looking for new for new people?
Yeah, we're looking for new participants. We basically have studies that are open for anyone with Down syndrome, age 18 and above here at UCI. And we're actually starting to explore the biomarkers of Alzheimer's, even in children with Down syndrome. So we have a small study at Children's Hospital of Orange County, Chalk, that Dr. Minadora Tatoyu, who works with us on the adult side of things here at UCI, is undertaking, where we're looking at blood biomarkers of Alzheimer's. So we're measuring analytes of amyloid and tau in children with Down syndrome now. And as I mentioned, we have sophisticated studies that include blood draws, lumbar punctures or spinal taps, PET scans, MRIs, but those sorts of procedures aren't for everyone with Down syndrome. They might not be comfortable with the amount of discomfort that might be associated with a blood draw or a spinal tap. But I just want to point out that we allow all persons with Down syndrome, regardless of their baseline of abilities and their willingness to undergo procedures like PET scans and spinal taps, to come in and allow us to study them and contribute to sort of unraveling the mystery of Alzheimer's in people with Down syndrome. So at a minimum, individuals would have to agree to cognitive testing, informant-based interview, neurological exams, and at least agree to attempt a blood draw. So we want to make certain all persons have an opportunity to contribute to the scientific understanding of this condition that will hopefully lead ways for us to prevent Alzheimer's.
Another question, Eric, will family history compound
Yeah,
for
that's a-
Alzheimer's or Down syndrome?
that's a good question, but we don't really know the answer to. Of course, family history of Alzheimer's is known to be a contributing factor to anyone in individual's risk to develop Alzheimer's. But in people with Down syndrome, that's really not understood yet. There hasn't been much research on that topic. The primary driving force for the development of Alzheimer's disease and dementia in people with Down syndrome, of course, relates to that triplication of the APP gene, but it's quite possible that there are other genetic factors that we inherit from our parents that modify that risk, either by increasing it some or decreasing it. But we just haven't done those studies yet. And then I see a question, is it advisable for young adults age 19 to 20-ish to do a baseline assessment? And I would say probably not. That's probably too young for a baseline assessment when you're concerned about Alzheimer's related changes. As I said, the current healthcare guidelines suggest starting at age 40 and above. There have been other guidelines in the past that suggest perhaps maybe even age 35 and above might be a good age to start. So, and I certainly wouldn't argue against that. Maybe age 35 and above would be a good time to start. And then I see another question here about the blood draws that we do on the research side of things. We do collect a fair amount of blood on the research studies, up to 4 tablespoons of blood or so. But as I said, not all participants in research have to agree to the blood draws, but it tends to be just a single poke with a butterfly catheter and multiple tubes. And we have a good research nursing staff here at UCI. And we're, of course, allowed to have family members accompany our participants throughout all of their procedures to try to make them as comfortable as possible. So I hope that answered your question about the amount of blood.
Also a question, aside from physical deterioration, does it affect the breathing also? We checked Robin's oxygen levels all the time, and it did affect her breathing, but I'm going to put that over to you, Eric.
You're referring to the sorts of breathing changes you saw in late stage?
Well, no,
dementia.
just, I mean, well, it was later on. It was in later stage. It was not in earlier middle that her breathing was compromised, but the question is.
It tends not to affect respiratory rate, but certainly lung health is often impaired in the later stages of an Alzheimer's dementia. As the disease progresses, it affects our autonomic nervous system, if you will. So the natural nervous system that controls our breathing and our swallowing, say, individuals can accidentally swallow liquids or foods into their lungs instead of their stomach. So that natural process by which our body is able to avoid doing that experiences dysfunction. in someone with advanced Alzheimer's disease. So you can see compromised lung health and recurrent aspiration pneumonias are very common towards the end stages of the disease. So then you can often see changes in breathing and lung health. I hope that answers the question.
But again, her oxygen levels were also compromised. Just, you know, we had to watch that. Any other?
It doesn't look like we have another question, so if anything else, we don't have any other questions, I think we can let Eric and
Copy
Sharon.
Eric's phone number down and call him. I recommend you call him. An amazing resource.
Maybe you can go to the end of the presentation. We're gonna post this presentation on the DSLA YouTube channel, but you can also take a photo of this page, or if you wanna keep it with you. And I would like to thank Eric Doran and Sharon Trocki-Miller for being with us today, spending their Saturday morning with us, and thanks to all of you for spending your morning here with us as well. I hope you guys enjoy the rest of your weekend, and thank you. Thank you so much.
Thank you. Bye-bye.
Thank you. Bye, everyone.
Thank you so much.